Yeah, so the rationale for this trial, and the trial is called ARNEO. So it is a neoadjuvant trial using Degarelix in all patients, but then we blinded and randomized patients to add placebo versus apalutamide. And the patient selection and rationale is very simple. We included high and very high risk localized disease. Why did we include those patients? Because we still have a major problem there. Even if we treat high and very high risk prostate cancer patients intensively, we still are losing patients. And if you look at all localized disease, this group is only at diagnosis a minor group. About 20% of all patients will have high and very high risk disease at diagnosis. But if you look 5 to 10 years further at who dies of prostate cancer, starting with localized and locally advanced disease, the majority of patients who die from prostate cancer using what we use today, surgery, radiation, and so forth, is for the major part high-risk prostate cancer patients. So we have an unmet need to improve those patients' survival. The rationale now to use apalutamide together with Degarelix is based upon the following facts. We know that in metastatic hormone-sensitive disease, apalutamide, enzalutamide, abiraterone, so new hormonal treatments, have a major impact in survival. Those patients, of course, they have detectable de novo or recurrent metastatic disease at imaging. But in this specific group, we also know that these drugs work also in the low volume disease. And in low volume disease, there's also an overall survival benefit. At the other hand, high and very high risk prostate cancer patients, if we scan them with PET scan, and we know that from the study by an Australian study where PSMA PET-CT was used in those patients by Dr. Hoffman, we know that a lot of those patients, 1 in 4 up to 1 in 3 of those patients will have micrometastatic disease already visible on a PET scan, and a lot more will have metastatic disease not visible on a PET scan. So they also have a lot of those patients micrometastatic disease. And if these drugs work in overt metastatic disease, in low volume metastatic disease, the hypothesis is that it will also work in micrometastatic disease. So that's why we set up this trial. It's a phase 2 trial. It's a formal double-blind randomized controlled trial. We included 90 patients. One patient eventually withdraw his consent and choose another treatment option. But the other 89 patients were randomized 1-to-1 in a group receiving only Degarelix plus placebo or Degarelix plus apalutamide. We, as investigators, and everybody looking at scans, doing microscopy, was blinded for the allocation of the groups. The patients were treated for 12 weeks before surgery and before starting the systemic treatment. And then after ending the systemic treatment, we did a PSMA PET MRI. And after the 12 weeks treatment, we operated all patients. All patients underwent radical surgery, radical prostatectomy with pelvic lymphadenectomy. Now, those patients, in those patients, the endpoint was set at minimal residual disease, which is defined as a disease volume less than 0.25 cc of tumor. And that was a definition already used in former studies in the literature. And the only studies we have so far are phase 2 studies like the ARNEO trial. The original parts of our trial were that we are the first to use apalutamide. We are the first to use PSMA PET MRI before and after the systemic treatment. And we can use the PSMA PET-CT to try to determine the outcome of the patients. And we used a set of immunohistochemical markers on the biopsy tissues before we even started the treatment to try to predict the outcome of patients. So what did we see in this trial? We saw a very significant difference in reaching minimal residual disease between the two groups. And in the group, the receiving Degarelix plus Apalutamide, 40% of the patients achieved the endpoint, whilst in those only receiving Degarelix plus placebo, it was just below 10%. So it was a major difference in minimal residual disease. Furthermore, we noticed that the PSMA PET CT, when you looked at the response on the CT, so the difference between the first and the second PET MRI, it was predictive of the final pathological outcome. And that's really very interesting because PET CT can now be used in future studies to really follow up the patient during neoadjuvant treatments in the hope of helping to determine who's responding well, who's not responding well. And then the non-responders, we may think of intensifying further the treatments in those patients. But that's future work. And of all the immunohistochemical markers, the very important marker that remained from all those tested was PTEN loss. If patients have PTEN loss on biopsies, they were very unlikely to respond to this neoadjuvant treatment. And so we have a diagnostic marker, which may be a predictive marker in larger studies, and it should be studied, in my opinion, in further large studies. Now, I hear you thinking, okay, so you've proven that an intensified treatment achieves a better pathological response, but pathological response does not equal oncological outcome. That's correct. But we know from earlier studies, Phase II studies, and Dr. McKay has already studied from several Phase II studies, the impact of reaching minimal residual disease or reaching a downstaging of tumor to lower stages, to stage T2 or less. If you reach that endpoint, there is a very low risk of reaching biochemical recurrence later on. So there is a link between a deep pathological response and much improved biochemical response in the long run. And so we expect, and we are following our patients, we expect that in our patient group, and those who received apalutamide had a much higher deep response, we expect that those patients will also achieve better biochemical responses and hopefully also hard clinical endpoints in the future, but we don't know yet. That is work for the future.